Good morning, everyone, for joining us in the rounds this morning. It's my great pleasure to introduce and Jamil. I'm gonna try to pronounce your last name. I'm not sure I'm gonna be able to do it properly, but Dr. Aboulhosn, and who is the director of the UCL ACSD unit, and he's gonna talk today about transcatheter pulmonary valve replacement, where we have been and where we are going. So Jamil, thank you for joining us 5 o'clock in the morning in LA, and the floor is yours.
Thank you so much, Dr. Alonso, and you know, it's always a pleasure to get together with colleagues, and especially to present to a program with the kind of wealth of talent and history that you guys have in Toronto. You know, we were just talking about this whole COVID thing, and when I was invited to actually give this grand rounds, I was debating whether to talk about the whole COVID study that we did in that global registry, but I decided I wanted to sort of move on and talk about something else. So let's not discuss COVID anymore, and let's instead talk about transcatheter pulmonary valve replacement. I do have a oops, sorry, for some reason my slides aren't moving. There we go. I do have a few important disclosures here as far as Edwards and Medtronic specifically for transcatheter pulmonary valve work that I do with both of them as a consultant and as a proctor for Edwards. And then ABIM, I will not be disclosing any questions. So let's just get right into it here. This is a famous slide. It's been shown many times at many meetings, but it highlights the fact that you know, patients with RVOT abnormalities are about 22% of all CHD patients. And if you look at the types of RVOT landing zones that we get in our repaired patients, whether they be tetralogy patients or otherwise, the vast majority of patients, especially tetralogy patients with pulmonary stenosis, end up with non-conduit RVOTs, non-bioprosthetic valve RVOTs. So, and those can be transannular patches, subannular patches, valvotomy procedures, so on and so forth, that result in a patient having, for the most part, an incompetent pulmonary valve, and you can have a mix of stenosis and regurgitation. But this 77% here that we're talking about, the large majority are going to be pulmonary regurgitation patients. And these have been the ones that we have really not had a great solution for over the last 15 years or so. As we've, you know, transcatheter pulmonary valves have come online, we've been able to address conduits, and we've been able to address patients with bioprosthetic valves that have fixed landing zones of given predictable diameters, etc. You know, initially with the Melody valve, we were able to get up to 22 to 24 millimeters. With the Sapien valve platforms, we're able to get up to 29 millimeters. But the big adult RVOTs that are up in the 30s and maybe even 40 plus millimeter diameter range, we have not really had a great solution for from a transcatheter standpoint. So I will end up giving an update on where we are with that and talking a little bit about platforms like the Harmony and the Altera. But the 23% there is what we've been able to get to over the last decade plus. So as you all well know, patients with tetralogy of Fallot, let's just focus on those for a little bit, are a heterogeneous population. Less than 20% are unrepaired or palliated, at least in the developed world. And in and of themselves, the repaired patients are highly heterogeneous. And I just looked at our database. This is from about 2.5 years ago. And in about 1,400 patients, we had about close to 50% of them had native RVOTs, and then about a quarter each were bioprosthetic valves or conduits of some type or another. And so many of these bioprosthetic valve and conduit patients, if they had issues that required replacement, we've been able to do these using initially the Melody valve platform. And then we moved actually a few years ago to the Sapien platform for a number of reasons, which I'll go through as we go on with the talk here. For our native patients that required valve replacement, we were either sending them for surgical pulmonary valve replacement, or in those that we thought were at risk for major complications with cardiopulmonary bypass, we did quite a few hybrid procedures that were open chest procedures, but not open heart procedures. And I'll go over how we do that as well. So issues to consider when it comes to these PR patients. So transannular patch patients, as a rule, have severe PR. And so, I always tell my colleagues in adult cardiology to look for this and suspect any reports of only mild pulmonary regurgitation if there's been a history of transannular patch repair. Typically, our conduit and bioprosthetic patients are going to have a mix of PS and PR. Arrhythmias are par for the course with a lot of these patients. About 30% of these patients will have atrial or ventricular arrhythmias, and often associated with hemodynamic abnormalities of PS and PR. And then we have to think about both RV and LV function, both systolic and diastolic function, keeping in mind the importance, the prognostic importance when it comes to arrhythmias, such as ventricular arrhythmias of LV diastolic dysfunction. Aortic root and aortic valve problems that can occur in this population, residual VSDs, etc. MRI is obviously the gold standard at this point, pretty much across the board for quantifying the amount of PR and doing volumetrics on the RV and such. But I think, echocardiography is very useful. And this kind of, transthoracic echo and a parasternal short axis view, usually these don't come labeled like this, but wouldn't it be nice if they did, where you see holodiastolic branch PA flow reversal or branch PA flow reversal that ends early in diastole with a sharp pressure half-time, sharp decline in the velocity here. That is very suggestive of severe PR. And then looking at things like the PR index here as well is important. And so we follow this algorithm. This is from a CART analysis that was published from our group back in about, I think it was 2010, where this is kind of a screening thing that we do looking for PR, where we look for branch PA flow reversal in diastole by color Doppler or pulse wave Doppler. If the answer is yes to that, and the PR index is less than 0.77, then we found, at least in this study, that there was a 100% likelihood that patients were going to have a PR regurgitant fraction of greater than or equal to 40% by MRI, versus if the answer is no to both of those questions, then it was 0%. So we find that this is a very nice and quick kind of screening way to decide which way to go with these patients. And obviously, we do try to get MRI, but it's interesting. There are restrictions in California, for example. California Medicaid does not cover cardiac MRIs. So there are these, the American medical system is an interesting one at best, sometimes completely broken, sometimes effective, but in this particular case, it can be a real problem for us to be able to actually get cardiac MRIs on patients. And so we have to use other techniques. And this is why echocardiography in that population is still really important. And when we follow this kind of algorithm, we are usually right on with it. As far as pulmonary regurgitation, I just want to turn your attention here, and specifically the fellows on the call. These are simultaneous RV and RPA or LPA waveforms. And what you're seeing here is pressure waveforms that look very similar to each other. And the pulmonary artery waveform shows a decrement in pressure in diastole, really back to the baseline there where it equals the RV diastolic pressure. And when you see this kind of thing where the pressure waveforms look very similar, then I think you need to really suspect that the patient has severe pulmonary regurgitation. And one simple thing is just even on fluoroscopy, if you put your catheter out into the branch PA and you see it moving back and forth in fluoroscopy like this, then just suspect that the patient has a lot of pulmonary regurgitation. You can do a branch PA injection. If you see that contrast come right back to the RV, then you have severe pulmonary regurgitation. So there's a lot of ways that we can try to identify it. By various types of imaging, and of course, obviously by physical exam. I like to show this MRI here, and this is just a cine coronal view here of a patient that has a subannular, and I think this is all almost transannular patch here. You can see some leaflets here, but they are not coapting, and there's just wide open pulmonary regurgitation, big RVOT, big PA. And this is the most challenging landing zone, because if you look at this, and it's very heterogeneous. It comes in all shapes and types and sizes. And this is why this has been the most challenging group to actually do transcatheter pulmonary valve replacement on, shown no better than in an image like this. So let's talk a little bit about pulmonary regurgitation. Usually it's after surgical treatment of PS or tetralogy of Fallot. Occasionally, it's from aggressive balloon valvuloplasty of PS. And in a growing number of patients now, we're appreciating, patients with carcinoid syndrome who may have a combination of PS, PR, and tricuspid disease, and patients with pulmonary hypertension who can have high pressure pulmonary regurgitation that's also difficult to treat. But for the most part, what we're seeing and dealing with, and historically, what we deal with are congenital patients, and those are PS and TOF patients. Typically well tolerated for a decade, 2 decades, but then you're dealing with progressive problems, progressive right ventricular enlargement, right atrial enlargement, atrial and ventricular arrhythmias, right heart failure, progressive tricuspid regurgitation, and then eventually, the potential development of multi-organ failure with progressive liver congestion, potentially cirrhosis, renal dysfunction, and so on and so forth. Right-sided problems are insidious in that they may take a longer time to present clinically, but by the time somebody is sick with right heart failure from something like chronic severe pulmonary regurgitation, then they're actually really sick. And so in some ways, it's easier to deal with left-sided lesions that present earlier and can be addressed sooner. If you look at, and this is from a study that was done through ARC, looking at atrial arrhythmia prevalence in repaired tetralogy of Fallot patients, and looking at age, and you can see that something magical happens here in the 40s and into the 50s, where all of a sudden these atrial and ventricular arrhythmia rates all go up. And so, patients with chronic PR really are coming to attention and having major issues in their 40s and 50s. And so many of the patients that we're now looking at to perform the Altera or Harmony valve replacement procedures are in that age range. This is from the same manuscript and just shows the atrial and ventricular arrhythmia prevalence rates if you break it down by the number of cardiac surgeries that patients have had. And this isn't to say that, cardiac surgery is not an important and necessary aspect of the care of these patients, but it does argue that the more sternotomies and the more cardiopulmonary bypass runs that our tetralogy patients have, the more issues we leave them with. And in this case, for example, you're looking at ventricular tachycardia, ventricular fibrillation rates exceeding 35% if somebody has had 5 prior cardiac surgeries. And so this kind of data really pushes us to try and do as much as we can in a less invasive way without cardiopulmonary bypass if possible. And so, what is our strategy at this point for treatment of, say, conduit and bioprosthetic valve dysfunction? Well, it's a tetralogy of Fallot kind of patient. Obviously, surgical treatments in the first few years of life are going to be the way to go. We're not going to be able to fix things in the cath lab, I don't think, in the first 5 years of life necessarily. However, when with somatic growth, after about 8 years of age, I think adult there should only have one T, sorry about that. We would begin thinking about interventional approaches at that point, especially if there's a large enough conduit here, or in the current era and going forward, if there's a native RVOT that can be valved with some of the current technology that we have. This is from the European Society of Cardiology ACHD guidelines that came out recently. And, they're actually very interesting in the fact that if you look here, okay, so this first one here, pulmonary valve replacement is recommended in symptomatic patients with severe PR and or at least moderate RVOT obstruction. Okay, that's a no-brainer, very good. But look at this here. Second one, in patients with no native outflow tract, catheter intervention should be preferred if anatomically feasible. So basically, the European guidelines are telling us that if you've got a conduit or a bioprosthetic valve, they would favor that we go with a transcatheter approach as opposed to a surgical approach. And it's interesting that it's a class 1 recommendation here, especially given the infective endocarditis issues that have come to the fore over the past, 6-7 years with the Melody valve. So I would have loved to have been a fly on the wall in that room to hear that debate. But it just tells you that this wave is now no longer something novel and new, but has now become the new standard of care for these non-native RVOT patients. And I think that what we'll find, and I'm going to make a prediction here, and I might be wrong, but I think what we'll find here over the next few years is that a similar thing is going to happen with native RVOTs, given all the platforms that we have coming out for the treatment of that. And then you've got the asymptomatic patient considerations here, and these are pretty standard. So in the United States, we've had the following. So we had the Melody valve, FDA approved in 2010, and that's when we started implanting it at our institution. And then we had the Sapien XT valve, which is a second generation Edwards Sapien valve, which is a bovine platform, but is a bovine pericardial platform, whereas the Melody valve is a bovine jugular vein platform. So the Melody valve is basically the Contegra conduit that is sutured into a platinum iridium platform, whereas the Sapien XT is a true bioprosthetic valve, and it's sutured into a cobalt chromium stent platform, a much stronger, tougher stent platform that's much more resistant to fracture. And it's very interesting that the FDA actually approved the Sapien XT for use in the pulmonic position, specifically in conduits, because it was basically off the compassion trial that hadn't even been published yet. But be that as it may, the Sapien XT was a fleeting valve that kind of came and went. And the Sapien S3, which was the latest generation, that's a third generation Sapien valve that had some other modifications compared to the XT, including the skirt here. These were all designed for the aortic position, not for the pulmonic position, but we used them in the pulmonic position. But it had a skirt here. It recently got FDA approved for use in the pulmonic position in bioprosthetic valves and conduits, but many of us were using it starting at around 2016, 2017. And then it became the preferred valve for use at many institutions with low infective endocarditis rates and no fractures that I'm aware of, actually. And it goes all the way up to 29 millimeters. So that's the key here, if you think about it. The Melody valve you can treat from 18 to 22 millimeters. But the Melody valve has certain other advantages. For example, the Melody valve works at as small a diameter as 12 millimeters. So if you have a tiny conduit and you need to valve it with something, you can put a Melody valve in there and it'll work. If you try to put a Sapien valve, even a 20 millimeter Sapien valve into a 12, 14, or 16 millimeter conduit, it may not work at all. And it actually will not work at those small diameters. So you really need to get your conduit or bioprosthetic valve up to a diameter that is 1 or 2 millimeters below that 20 millimeter mark before a Sapien valve will actually work. However, the Sapien valves go all the way up to 29 millimeters. And the Sapien S3 valve, if you end up actually putting more volume into the balloon, I typically, and it drives the Edwards people crazy, but I typically have an extra 5 cc's that I'm ready to actually inject. I can get the Sapien S3 valve to an outer diameter that's close to 32 millimeters. So, and it still works well. The valve leaflet's still coapt, and you know, you might get a mild PR at most, but it does a pretty good job even at those sizes. But you're not really going to put it in to somebody who has a native RVOT that's larger than 29 millimeters in diameter. And that's where we recently now, just in the last, in March, I believe, had the Harmony valve approved. This is from Medtronic. So this is a Medtronic product, the Melody. The Sapien valves are Edwards products. And then Medtronic came back with an excellent product here in the Harmony valve. And the Harmony valve comes in 2 sizes now. It's the Harmony TPV 22, which has a really niche kind of patient population in which it can be used. It was the first Harmony valve that we were testing in clinical trials, and it was very frustrating actually, because we would screen 10 patients and only 1 patient would fit. So it just didn't capture the vast majority of our native RVOT patients. However, the Harmony TPV 25, this bigger one here, is absolutely fantastic. Look at the size, 43 millimeters up top, 54 on bottom here, 51 millimeters in length. Anatomical sizes, these are perimeter derived from ECG gated CTAs, and you're going from 25 to 38 millimeters up top, 32 to 48 millimeters at the bottom. So really this is going to get about 80% of native RVOT patients. Some will still be too large for this, but we are now implanting this under a commercial basis since it was FDA approved and has been a major step forward. These are all balloon expandable platforms here, Melody, Sapien 3 and Sapien XT, and this is a self-expanding platform. And it's basically cloth with nitinol that is sutured onto it, a highly flexible platform, and it's just unsheathed within the native RVOT. So here we go. This is an example of a dysfunctional conduit with a bioprosthesis inside of it. These are the various kinds of landing zones that we can have in place, the non-native landing zones, from bioprosthetic valves to synthetic conduits to homografts here, aortic and pulmonary homografts. They're all great, but you know what? They have a finite lifespan and will need replacement. You know, and typically we're looking at a median of 15 years. This is the UCLA experience up to the end of 2019. And if you look, we started out with the Melody valve here, that's in gray, in 2010. And the Melody valve kind of dominated the valve implants that we did all the way through to about 2017. But then you saw the Sapien XT make an appearance here in 2014, 2015, and then the Sapien 3 come online in 2016. And I can tell you, over the last 2 to 3 years, we have been almost exclusively using the Sapien 3 or occasionally the Sapien 3 Ultra, with really diminishing numbers of Melody valves, to where in 2020 and 2021, I believe I put in only 1 Melody valve for multiple reasons, including really significant endocarditis rates that we've had at our institution and a number of deaths. And we made a decision that we are moving towards the SAPIEN valve platform for the most part. And we've been happy with that decision because we've had quite low endocarditis rates, at least up to this point, with our SAPIEN 3 platform. The blue here are the Altera and Harmony valves that we started putting in, or Altera is not a valve, it's a stent that you then put the SAPIEN 3 valve into, and I'll go over that in a bit. But what you've got here is these increasing numbers of other valves. The SAPIEN 3 Ultra is basically an alteration to the skirt of the SAPIEN 3, but it's essentially a SAPIEN 3. This is the Melody valve here. Beautiful valve, really, and a beautiful concept. And it comes in two types. It comes in the column, the big boy and the small boy there. The Melody TPV 20, which is acceptable deployment up to 20 millimeters. The Melody TPV 22, which goes up to 22, but you can really get it up to 24 millimeters if you mount it on a 24 balloon. If you try to expand the Melody beyond 24 millimeters, it just starts to leak badly. And I know some early data out of Boston showed that you could use it in high pressure circuits in people with PH, but really our experience has shown us that the Melody valve is not great in hypertensive circulations and systemic circulations, especially in adult patients. Those leaflets are very thin and they really don't withstand the high pressure well. Whereas the SAPIEN valve platform, which is designed for the aortic position, is, I think, much more durable in that position. At least that's been our experience. Tetralogy of Fallot here with a stenotic homograft. This is one of the first patients that we did, and you can see here how tiny this homograft is. And this patient actually just came back to see me recently and unfortunately now has endocarditis, which we are almost certainly going to have to surgically treat. He's done well with medical therapy, but we start by trying to stent the conduit. And back then, this is back in 2010, we actually didn't have any FDA approved covered stents in the United States. So we were sitting there trying to expand these highly calcified homografts with uncovered stents, which is just a dangerous proposition. But after putting in something on the order of 4 different stents here, we were able to rehabilitate the conduit enough to put a Melody valve in here and end up with very little in the way of pulmonary regurgitation, but mild plus pulmonary stenosis. This is a down the barrel view that shows that it is, almost circular. Sometimes, if you just try to put in a Melody valve in these, it'll be pancaked and the fracture risk is very high. So you have to pre-stent them, and often multiple pre-stents to rehab these conduits. The clinical and hemodynamic outcomes over time, and this is published as a 7-year study, but actually if you look at the numbers, it's really more of a 4 or 5-year study. But be that as it may, the reintervention rates are not low here, especially in the original IDE trial here. And why is that? Because at the beginning of that trial, they were not pre-stenting. So they were just putting in the Melody valves, and they had a fracture rate that was over 30%. So the argument here is anytime you're putting a Melody valve into a conduit, you should pre-stent. With a SAPIEN, you don't necessarily need to, although we often do to rehabilitate the conduit, but the SAPIEN valve has a much lower fracture rate. So, and this is for the SAPIEN 1 and SAPIEN XT valve in the original compassion trial, as far as reintervention rates and endocarditis rates. So a bit lower, but mostly because there's less fracture. This is an interesting concept here that's now become standard for us, which is basically fracturing any bryoprosthetic valves that we can. This is a 19 millimeter mosaic valve here, and see a high pressure balloon here going up to like 12 atmospheres, or actually in this case, they went up to 20. Actually, I don't know what atmospheres they went up to in this particular video, but usually the Medtronic mosaic valve will fracture at about 12 atmospheres. And you can hear the pop there. And oftentimes you'll actually hear it while you're doing the case. So this is an example of somebody that had a 23 millimeter mosaic valve with a true internal diameter of only 19 millimeters. And so we start out with a relatively small balloon here, and you can see that there's quite a bit of stenosis, but this is a very high pressure balloon. So we go up with that, and then we eventually fracture the valve here with a balloon that's usually 2 to 3 millimeters larger than the true ID. So we were able to actually fracture this valve and get it up to, that's a 26 millimeter balloon here. So we got it up to at least 24 millimeters. You can see there, and this is, I'm showing this also to show you that you can get compression of one of the aortic sinuses here, which is not a problem if you don't have AR. And typically makes it look a lot worse here because you've decompressed the aorta by basically stopping all cardiac output. So actually, once the aorta is pressurized, it doesn't look like this anymore. And you're looking obviously for coronary compression, which we don't have. But here we were then able to put in a 26 millimeter SAPIEN 3 valve by fracturing the bioprosthesis first. So that's just become standard now. Fracture the bioprosthesis, get the largest possible transcatheter valve in that you can. Why? Because the larger the valve, the lower the residual gradient. The lower the residual gradient, obviously the less RV pressure overload you're going to have, but also if you look at now multiple studies, infective endocarditis is much more likely in patients with a residual PS gradient in the cath lab, peak-to-peak gradient of greater than 15 millimeters mercury. So we really want to try to get that gradient down. And you can see here with our SAPIENs that are larger diameters, 23, 26, 29 millimeter diameters, we progressively get lower and lower gradients. Whereas here with our Melody valve platforms, lower diameters, we have higher and higher gradients, which actually in some ways, disadvantages the Melody valve when you're looking at endocarditis rates, because it is being put into a less friendly environment, right? Smaller conduits and smaller bioprostheses. So what are the issues when it comes to treating native RVOTs and native pulmonary regurgitation? Sorry, was there a question? I'll keep going. What are the problems? Well, we've got big RVOTs, we need big valves, we need big delivery systems. We're basically trying to drive these trucks in from the femoral vein through the tricuspid valve, out into the RVOT, find appropriate PA positions. So they're difficult cases, especially when the RV is huge and quite dysfunctional. So this is an example of the SAPIEN XT valve. And one of the reasons we stopped using it pretty quickly. Sorry, let me go back and just play this. So it was extremely difficult to actually get this system, this is the Novaflex system that's designed for the aortic position, to actually get into the pulmonic position. Look at the RA loop we had to go across the tricuspid valve this way. It took a lot of twisting and turning, and the system's just not meant for it. And this is the first one I did. And it scared the hell out of me. You know why? Because the balloon just wasn't going up easily. I said, something's really wrong here. Balloon's not going up easily. And I said, okay, well, I'm kind of committed here, so let me deploy this valve. I deployed the valve, and now I go to take the balloon down. The balloon isn't coming down. Couldn't get the balloon down. Heart stopped. This is 30 seconds of not being able to take the balloon down, eventually having to just pull it out. And what had happened here is this system, I'm not going to keep showing it because it's just horrific, but this system is not designed to be torqued in the way we need to torque it to get it through the tricuspid valve and out into the RVOT. So it actually twisted the balloon shaft and made it impossible for the balloon to be fully deflated. So I had to untwist everything eventually to be able to deflate the balloon and pull it out. So this highlights why we need systems designed for congenital heart disease, for the RVOT position. And, Edwards is now working on a pulmonic delivery system for the SAPIEN 3. So that's great. But this SAPIEN XT delivery system was just not a go for us. And so we very quickly moved away from it. This is the SAPIEN 3 valve in a native RVOT. And you can see here that there is some calcification to this valve here. This is a patient who had PH. You do the balloon sizing here. And with balloon sizing, you've got a nice waist on a 30 millimeter balloon. And then we don't even bother pre-stenting. We just go ahead and put the SAPIEN 3 in there, and it works beautifully. And honestly, this is, in my mind, the best way to replace a pulmonary valve. Why? You got a huge valve in there. The internal diameter is 28, 29 millimeters. especially if you're expanding it to above 29 millimeters. You've got basically no gradient through the valve. It works beautifully. You haven't put a lot of hardware in there. So we have a bunch of these patients that we've put these big SAPIEN 3s into, and we've been very happy with the results for the most part. But it comes at a price sometimes. And this, again, has to do with the delivery system. So you do a case like this. Sorry, I'm going to go back here and just play this. This is intracardiac echo. You do a case like this where you replace the pulmonary valve and it looks great and we're so happy, but something's wrong with the patient. The blood pressures come down, the cardiac output came down. So we take a look at that tricuspid valve and look at what we did to the tricuspid valve. So we just completely ripped the tricuspid valve. And this was happening in about 6% of patients that were getting the SAPIEN 3 using the Commander system. So at that point, we said, oh my Lord, we're now dealing with a problem that we have to solve. And so this is how we began using what's called the 26 French dry seal system to essentially not push the SAPIEN valve exposed in any way through the RV, because we were catching tricuspid valve cords with all the back and forth and tearing the tricuspid valve. And then so this patient actually ended up requiring surgery here. So acute complications that we had in 107 patients that got the SAPIEN valves, the SAPIEN 3 valves. Look at this, 4 patients with tricuspid regurgitation, many of them requiring surgical TVR, and then some other issues here related to valve migration, pulmonary artery perforation, LAD compression, aortic compression, etc. Listen, this is a contact sport. You know, you're going to get occasional complications, and we should be very honest about our complication rate. But we were very concerned about the tricuspid regurgitation, and this is why. Look at what we have to do, even with the SAPIEN 3 Commander delivery system. This valve is uncovered as it goes through the heart here, and you can imagine all these tricuspid valve cords here going to the septum, going to the RVOT, and we're just basically moving this thing back and forth, and uncovered valve here, stent platform that can catch cords this way and can catch cords this way, and you can just get entrapped in the valve, in the tricuspid valve tissue. And so we really needed to solve this problem, and the solution was this, which is the 26 French, well, it comes in 22, 24, and 26 Frenches that are all useful, but the 26 French is for the 29S3 Gore dry seal. So this is not meant to be used in the pulmonic position, but look at what happens when you actually put it up there. So it's a huge sheath, but you get it up there, and now you've created, it's almost like the channel. So now look at this, you can put this valve right through it there. It's like a subway, and there's no interaction with the tricuspid valve, with the SAPIEN valve there, so that's wonderful. We position the SAPIEN valve, and then we pull back the dry seal sheath, and then we inflate the SAPIEN valve, and we are happy with the result. And now we have not injured the tricuspid valve. And ever since we started using the dry seal, we have not had any more tricuspid valve injury. So, and now it's actually being used widely. And as a matter of fact, in the SAPIEN S3 FDA approval, they even state that the dry seal can be used, and most institutions will use it now. And it has a reduction in procedural time as well, which is nice. So what is our strategy here? If they're homografts or conduits and they're calcified, we generally now will put in covered stents, followed by these bare metal stainless steel platform stents with greater radial force. And then thereafter, we'll put a SAPIEN valve depending on residual waste. Valve-in-valve bioprosthetics, we do not pre-stent. I don't know if Eric Horlick's on the call, but I think Eric used to pre-stent these. I'm not sure he still does, but we generally do not pre-stent these. We just lay the valve in those. And for native RVOTs here, these we occasionally will pre-stent, but most of the time now we'll just go up with a big SAPIEN and implant it if we have a waist less than 30 millimeters. Endocarditis, this is the elephant in the room when it comes to these procedures, and which is why I'm a little surprised that the ESC went with a class 1 indication. But if you look at the Melody valve here, you know, we're talking about an 11% endocarditis rate here after 5 years. And I can tell you in our experience, we're about that as well. This is a CART analysis that we published looking at immune status, residual gradients, history of IE, and seeing, as you can tell, I like these CART analyses, these yes-no sorts of algorithms. But if you start with the question, does the patient have immune compromise? And how did we define immune compromise? We said, well, if they have HIV/AIDS, if they're on immunosuppressive medications, if they have some known immune deficiency syndrome, including those that had DeGeorge. So we did include DeGeorge patients in this. And so if we start with that question and the answer is yes, so let's say we have a DeGeorge patient, then if we do a transcatheter valve, the risk of infective endocarditis, at least at UCLA, is 21%. If you then leave them with pulmonary stenosis with a peak gradient greater than or equal to 15 millimeters mercury, this is in the cath lab, not Doppler. This is direct pressure gradient at the end of the case. If it's greater than 15 or equal to 15 millimeters mercury, then nearly half of our patients ended up with endocarditis. Very scary. The majority of these were melody valve patients, but it wasn't necessarily just the melody valve issue. It was really the substrate into which we were putting the melody valve and the degree of stenosis that we were leaving. Then if you go down the other side and you go, no, they're not immunocompromised, the risk is down to 5%. But if they have a history of infective endocarditis, then the risk goes up, and especially if you're leaving them with PS. Now we've got a 25% risk that those patients are going to develop infective endocarditis. So what message does that give me? Well, what that tells me is maybe it's not a great idea to put these valves in immune compromised patients, but if you're going to do it, you better get a very good result. And definitely the same thing applies to those that have a history of infective endocarditis. But if you don't have immune compromise, if you don't have a history of infective endocarditis, and if you leave somebody with a minimal gradient, so your big native RVOT patient that's never had endocarditis, then the risk of endocarditis in that population is much, much lower. So, there are ways that we can sort of get at this in a more nuanced way than to just say, well, endocarditis risk for everybody. There are certain patients in our population, these are the patients that we worry about most. This is an example of a hybrid procedure. This is a procedure I did with a group in Bangkok, in a 10-year-old Thai boy here that has a huge native RVOT. And obviously, for a balloon expandable valve, not really an option. There's some residual tissue here. So we thought, well, let's do some balloon sizing. And they did this before I came. And there's a slight waist there, but it's a little over 30 millimeters, so a little too big for the largest sapien valve. So what did we do here? Well, sternotomy, and then basically placing a tricuspid annuloplasty band. This is the Edwards Physio ring that is then placed basically as a band right there. And then, quite simply, you go in through the base of the, or the inferior wall of the RV here, line up the valve and inflate the valve. And the valve sits nicely in that location, and there's no PR, so we're happy with that. But there is a consideration here, which is where are the coronaries? And so if you look right there, there's that left coronary runs right under the valve there. We did do coronary compression testing, and there wasn't any, but you can see there's a little interaction there. Now, the child did great, no issues whatsoever, recovered nicely, but this is why coronary compression testing is so important. Let's talk a little bit more about the Harmony valve platforms here. Basically at this point, mostly using the TPV25, goes through a 26 French system. We get this kind of analysis from Medtronic based on our ECG gated CTs, where they do the analysis at 30% systole and 90% of the cardiac cycle in diastole. And they give us this sort of, just really nice report that tells us what our landing zone is there for the top of the valve. And then they give us these kinds of interference plots, this fit analysis that shows the valve platform, shows the RVOT/PA in systole and diastole. And if it's green here, it means we have good contact up top and at the bottom here. And you can tell this would be a good fit even if it dropped lower, would continue to be a pretty good fit. So they then also will even give us estimated projections, viewing projections in the cath lab based on these CT images. So in this case, we want to try to get cranial 40 degrees, and then this is just a pure lateral view here, would be used for this deployment. And then you go into the cath lab and you go ahead and you put the valve in. So you do your usual angiography, sorry, that's Altera, and then this is after implantation of the sapien valve, and this one dropped a little bit low, and there is some perivalve regurgitation that resolved with time. And then this is what it looks like on intracardiac echo. So we do ICE on all of these, and it's a nice way to look at some of that perivalve regurgitation. You can see a little perivalve flow there, not entirely unexpected. And then this is the MRI a few months later, and you can see how it sits within that RVOT. Expect some VT and PVCs, just expect that. And so many of these patients I'm sending home after these kinds of implants with low dose metoprolol, and I put like a Zeo patch or a CAM monitor on them for a week. Most of them I've been able to take off the beta blocker over time, and the ventricular arrhythmia settle down. But you know, you're putting a large platform here into the RVOT, and there's going to be some interaction. So we shouldn't be surprised by that at all. This is the Altera adaptive pre-stent, which is a nitinol frame, open cell at the end there. Landing zone is in the middle, meant for a 29S3. It's a bit shorter than the Harmony TPV25, and it doesn't quite go up to the same dimensions inferiorly. And it's a two-step process. You have to put in the stent first. So you start out by doing the angiograms per usual. I'll go next here. This is the deployment there of the Altera, which is, again, this sort of very same kind of process where you're unsheathing it, and then you put the sapien valve inside of it. And this one has a little perivalve regurgitation as well, but typically, again, that gets better over time. This is the venous P valve. This is a procedure I participated in Asia. We don't have it here in the United States, but it's a Chinese valve, but it comes in many more sizes. And again, it's the same kind of concept, self-expanding kind of platform concept with this hourglass kind of design to flare up top and to interact at the bottom. So conclusions, transcatheter pulmonary valve replacement is feasible. It's effective in the majority of patients with native RVOTs as well now. Appropriate patient selection is imperative. Infective endocarditis is a big issue. And I think, as I've highlighted, there are certain populations that are going to be at the highest risk. Those who have residual PS, those that are immune compromised, those that have a history of endocarditis, in my mind, are the ones that you should consider at the highest risk. Aortic and coronary compression should be assessed. And coronary compression, I didn't show any of our data on this, but we have done work on this and published on this, that coronary interaction, coronary compression can be suspected based on the CTAs beforehand. So if you have a coronary that runs 3 millimeters or less next to a conduit, and if you have a conduit that's up against the chest wall and can only expand backwards towards the coronary, then that's very high risk of compression. Add to that, if you have an anomalous coronary or reimplanted coronary, then the risk goes up even more. So there are ways that you can actually assess this by CT beforehand. And that can be helpful, especially in severely calcified conduits where you don't want to be really aggressive with the ballooning. You want to put a covered stent in at a relatively small diameter. I'm generally reassured if I know that the coronaries are relatively far away by CTA. The balloon expandable valves were, you know, with the Sapien S3 up to about 29 millimeters at most, but really the RVOT reducer platforms, and in the United States, right now, the Harmony platform, which is FDA approved, the Altera platform, which is in clinical trial testing. It's now in the continued access phase of the trial and has been reinitiated, is also showing a lot of promise. So I think that is going to be another option that we're going to have, and maybe eventually the venous P valve. So I thank you very much for your attention, and I'll take any questions.
Thank you, Jamil, for an excellent presentation and review of all the technology we have available for the RVOT. So if you want to ask any questions, just either unmute your microphones or type it in the chat and you can ask directly. So Jamil, I have a couple of questions. So the first question is, I love your graph where which patients are at risk of having endocarditis. So have you changed or do you consider or change that approach when you consider to have a valve replacement? So you have somebody with the George that would be a good candidate for a percutaneous approach because of what you have shown that the patients immunocompromised have a higher risk of having endocarditis. Would you send that patient directly to surgery and wouldn't offer a valve, or you just try to offer the valve and not leaving any gradient? I'm really concerned of, I think the gradient is a key factor, but so which is your approach after you have seen that interaction?
Yeah, so that's a great question. I have a very serious discussion with the patient and the family regarding the infective endocarditis risks. And it all depends on, if the patient, let's say it's a fully grown adult patient who only has an 18 millimeter homograft in place and it's heavily calcified, and they have DiGeorge and a history of infective endocarditis, then in my mind, that patient is better off just going to surgery and getting a larger conduit, because I'm not going to have any chance of getting that gradient down to below 15 millimeters mercury. If the patient is at such high surgical risk that they're felt just not to be a candidate, and I've actually had exactly this kind of situation where the RV wasn't huge. The main problem was PS. I actually didn't even implant the valve. I just put a stent in and opened it up as widely as possible. I think if I'm going to implant the valve in that setting, then I'm probably going to lean towards anticoagulating the patient. We do know that, thromboses of these valves is often the sentinel event that then leads to further issues. But yeah, that's the kind of patient that I would walk away from, I think, or push towards surgery. Now, let's say the same kind of patient has a bioprosthetic valve that is, say, a 21 or 23 millimeter mosaic valve with an internal diameter of, say, 17, 19 millimeters, then I may approach that a little bit differently, because I know I can fracture those bioprosthetic valves. If it's a mosaic valve, say, I can fracture that. If it's a Hancock, I won't be able to fracture it. But if it's a fracturable valve, then now I'm fracturing the valve and trying to get it up to the largest diameter possible and really jam in there the largest size sapien that I can. So that's kind of how I'm approaching it now. But yes, having a lot of internal discussions with the patient and the family, and being really diligent about, I get dental clearance on all patients. I give patients a handout regarding endocarditis risk. I inform them about it at the time of the pre-procedural consultation, at the time of discharge, at the time of follow-up. I don't like to do mercenary work, meaning that I don't like to have patients referred to us where we put in a valve and then off they go back to their provider and then we never see them again. So one of my demands that really annoys referrings is where I just say, listen, if I'm implanting a valve, this patient has to come back to see me. Why? Because otherwise I hear back 3 years later that they now have infective endocarditis and that they called their doctor and were given a Z-Pack or something, because they thought they had sinusitis. So I think the way to mitigate this problem is, be judicious about in whom we put the valve, and also follow them up at centers like your center, our center, other centers that deal with this a lot. And if they do have infective endocarditis, and I didn't go into this, this is a complete other talk that I have about how we treat it, a lot of them can respond well to just medical treatment. And we have not had to do surgery on everybody.
So there are several questions in the chat. So Dr. Wernoski has two questions. One of them is a quite broad question. So if you could briefly go over the indications to proceed versus waiting for implantation. I think this is self a talk. The second question is easier to answer. It's the wonderful paper you wrote about arrhythmias in 2010. looked at ages at the age of 50, meaning surgery was in the 70s. So basically the question is, do you think the arrhythmia burden will be the same 20 or 30 years from now after switching the early repairing infancy? So we have changed the population we are looking at and the approach to repair, and is going to be arrhythmia problem in the next 20 or 30 years.
Yeah, so great questions, Gil. I think if you don't mind, I'm going to pass on the first one because it'll take me about 10 minutes to go through all of those. But as far as the second question, I think almost certainly we're going to have a change. But I don't know, again, arrhythmias are the Achilles heel, right, of ACHD. And what we're seeing a lot of now is as people enter their 40s and 50s, this concerning change from organized arrhythmias to AFib, right? And I think you guys are probably seeing it too, a lot more atrial fibrillation in our aging population. So are we still going to deal with that issue, especially in those that underwent multiple cardiopulmonary bypasses? I don't know. I don't have any way of knowing with certainty, but I would hope that this paper from 2010 becomes obsolete by 2030, and that another paper comes out that doesn't show those arrhythmia risks after multiple cardiopulmonary bypass procedures. But I guess I would turn it around and argue that why would we even need to do more surgery on a tetralogy patient, say with a native RVOT type repair after 8 years of age, if we have these platforms and they can fit the patient appropriately? And yes, we might have issues, technical issues with the valves, and those will be sorted out and solved, etc. But my hope is that after 7, 8 years of age, many of these patients will just require transcatheter treatment. And especially, when you're putting in these big SAPIEN valves, the 30 millimeter or 29 millimeter SAPIEN S3 valve, you can put valves in that till the cows come home. You're not going to develop patient prosthesis mismatch. So in my mind, that kind of platform is favored over a surgical platform. And so hopefully we won't have more of these graphs that show that your tetralogy patients, are requiring 5 surgeries. And hopefully they'll require 1 or 2 surgeries, and we can do transcatheter work thereafter, at least in the majority.
We have two technical questions. In the calcified conduits, how do you assess coronary compression after putting the covered stent? And which balloon are you using for compression testing?
Okay, great question. So this is why, and I should have cited this paper, our group and the group at Ohio State, John Cheatham's group, combined our data with our pre-procedural CTs and found that CT angiography is quite predictive of which patients you're going to compress and which patients you're not going to compress. So now you've got these competing risks, right? One risk is coronary compression, and you want to try to get the largest balloon possible before implanting the valve so that you can truly assess for coronary compression. And then you've got the other risk is you have an eggshell heavily calcified conduit that you are going to rupture if you go really aggressive and try to open it up to the diameter at which you're going to then stent and put the valve in. So how are you going to mitigate that risk? Well, in my mind, the way I mitigate that risk is I look at the CTA. And if the CTA shows that the coronaries are far away, then now the main concern I have is to limit the risk of conduit rupture. So what I will do at that point is I will not be super aggressive with high pressure balloons. I'll go in, I'll lay the covered stent in first, and then I'll be aggressive with ballooning thereafter. And I'll usually do a covered stent first, and then a bare metal stent inside of it, like a Palmaz, sometimes 2 Palmazes. But I go with Vita balloons or true balloons. Those are sort of my high pressure balloons that I go with. Occasionally we have Atlas Golds or Atlas balloons we used to use, but those can take up, the Vita balloon I can take up to 18, 20 atmospheres, and that's good enough to fracture any valve and really will expand most conduits. But I really, my
approach is I use the pre-procedural CT angiogram to judge coronary distances, coronary anomalies, and look at some of these relationships, like if a coronary runs right behind a conduit, and the conduit is right up against the sternum or the chest wall, then you're almost certainly going to compress that coronary, because that conduit has nowhere to go. It's going to go back towards the coronary. On the other hand, if the conduit is not up against the chest wall and the coronary is proximate, then your risk is actually lower. Even if the coronary is within 3 millimeters, it becomes lower, because now the conduit can expand in both directions. Does that make sense? So, you know, there's an art to this. This is not something that you can completely just make algorithms for. But, you know, if you look at what people die from, it's not just coronary compression, right? It's also conduit rupture. So basically get a CT beforehand on all these patients and assess it yourself. This is where, you know, the radiologists and the, you know, imaging folks are great, but the interventionalists themselves needs to know how to read these studies and really, you know, assess this risk. And it's become so important now with these native RVOT platforms to actually have, you know, rendering software like Osirix, for example, that allows you to do multiplanar reconstructions, so you can judge what these diameters and perimeters are and decide whether this valve can fit or cannot fit, where the coronaries are, etc. So that's how I approach it.
So we're beyond the time, but there's a last question that from Nikki Walker from Scotland. So thank you for your elegant talk. Is there any experience of cardiac surgery after the RVOT reducer? So is the patient going to need an RV2PA conduit, or the stent can be removed and the patient can have just a PVR without losing the RVOT to PA continuity?
Yeah, that's a great question, and the only way I can answer that is to say that there have been no more than a handful. I'm aware of one patient, but there's probably two patients, but there may be more, but those are the ones that I'm aware of. And there's one specifically that I'm aware of at a different institution that had to go to surgery after a Harmony valve that had migrated northward and was basically causing irritation to the roof of the pulmonary artery. And there was another patient where it migrated into the RV that required surgery, but those did not require any kind of conduit to be done. I think those were just bioprosthetic valves that were placed. And I can't imagine that will need to happen. I think this valve could probably be peeled off the RVOT and the PA distally at the time of surgery, should that be necessary.
Mm-hmm. Okay, Jamil, so I think that it's 9:10, and we have to, unfortunately, to finish here, because it would be lovely to continue with the discussion. And so thank you for joining us. It's already daylight in LA. We can see behind you that.
Yeah. There you go. I might jump in my pool today.
Yeah. So again, thank you for joining us so early today, and for the great talk, and for the attendees, thank you for joining us, and we'll be here next week. And good morning, good afternoon, good evening, wherever you are in the world. Thank you, Jamil. Bye-bye.
Thank you. Appreciate the invitation. Bye-bye.
Bye-bye.